Good afternoon and welcome everyone to our information and support session. My name is Kathleen Helgeson and I'm the coordinator of the Patient and Family Resource Center. The ways that we can treat cancer have become more personalized. New treatments recognize that each individual is unique and there is no one-size-fits-all approach. This afternoon, we are joined by Dr. Shantanu Banerji at Cancer Care Manitoba, a medical oncologist, and researcher Dr. Sachin Katyal, who will be helping us understand the advances being made in precision oncology. We will also be hearing from Bev, one of our patient partners, about the role patients can play in cancer research and as advisors. And behind the scenes, we are also joined by Dr. Megan Delisle, surgical oncologist at Cancer Care, who helped us coordinate this session today. We're very pleased to offer this session with the generous funding support of the Cancer Care Manitoba Foundation. I'd also like to acknowledge that we're meeting from all regions in Manitoba, the traditional land of the Anishinaabe, Cree, Ojibwe, Cree, and Dene people, as well as the homeland of the Métis Nation. It's important for us to foster inclusivity and reconciliation and encourage others to do the same. Before we continue, there are some basic Zoom features I'd like to explain. You'll notice as an attendee, your microphone and your audio are turned off. If you think of a question at any time during the session, just click on the Q&A icon and type your question. You can also choose to ask that question anonymously by checking the Send Anonymously box before you click on the Send button. My coworker Ellie is also here off screen and will be helping manage your questions as they come in. If you have a technical concern, you can also ask Ellie through the Q&A and she will answer your question privately and try to assist you. So welcome to all our guests. Thank you for being here. It's my pleasure to first introduce Dr. Banerji. Dr. Banerji is a medical oncologist at Cancer Care Manitoba with a practice focused on lung cancer and sarcoma. He's also the director of precision oncology and advanced therapeutics. His laboratory at the Paul Albrechtsen Research Institute is focused on the application of comprehensive genomic profiling to guide cancer discovery and treatment. Welcome, Dr. Banerji. So many patients I know are familiar with the conventional methods of treating cancer like radiation, chemotherapy, and surgery, but more and more we hear these terms like precision therapy, personalized medicine, targeted therapy, and it gets a little bit confusing. Everything is, advancing quickly and new things are coming out, but are these terms interchangeable or are there actual distinctions between these different types of therapy?
Sure. Thanks for the question, Kathleen, and thanks for inviting me to join today. I do have a few slides that I hope will help the audience sort of walk through some of these distinctions. So I'll just take a moment to just share my screen here. I hope that's visible to everyone.
It is.
So we're here to talk about personalized medicine and precision medicine, and in many ways the terms are interchangeable with some slight variations, which I'll briefly cover. So when we look at the treatment of disease, and this doesn't necessarily apply to cancer, this would essentially apply to every situation where we essentially apply therapies. We have a situation where someone in the population will develop symptoms. This could be symptoms related to high blood pressure, cholesterol, diabetes, or cancer. And the traditional approach is to make a diagnosis based on clinical parameters and then recommend a treatment. But as many of us are aware, and this is quite pronounced with cancer, is that when we prescribe a treatment, it doesn't work in everyone. There's some patients where, yes, there's absolute benefit, and these are the patients where we really expect this treatment to have value. But there's other scenarios where perhaps the treatment over time is no better than alternatives. And in some patients, it may actually cause harm or make the situation worse. And kind of doing this in sort of a blind fashion is the historical approach of medical care. But as you can appreciate, it's not always the right way forward for our patients. In cancer care, we take this traditionally one step further, which is we've always tried to personalize the treatment of an individual coming in with cancer. But in many situations, we personalize this based on the type of cancer. And we tend to give these broad labels of what we call either lung cancer or breast cancer, colon, prostate. And this is often determined by where the cancer is, we think, arising from, as opposed to any biological feature. And then based on that knowledge of where it's coming from, historically, we've personalized treatment by offering chemotherapy, usually what we call cytotoxic chemotherapy, that is specific for that type of cancer. But again, we run into the same issue where in some patients the treatment will work, in others it might keep things at bay, but in others still it may cause a deterioration. So where precision medicine is coming in is really trying to say, okay, how do we move away from these more generic treatments like chemotherapy? And how do we give more precise treatments that are likely to have a better effect in our patients? So first of all, we have to remind ourselves, well, what is chemotherapy? The sort of common term I use for chemotherapy is it's basically antibiotics for humans. The same way when a doctor prescribes you an antibiotic, the reason it kills bacteria as opposed to harming your body is that those drugs are specific for bacteria, but not humans. Whereas chemotherapy are essentially toxins or antibiotics that are specific for human cells. And these damage cancer cells, but they also damage human cells. And that's why they have toxicity. We take advantage of that toxicity to try and kill cancer cells and improve survival. But that's really limited to the people who can tolerate the treatment. And they can, the ability to tolerate it is limited by the side effects. And so where science has really pushed us and where the field has really gone in the last 20 years and where I get excited every day is through the advent of what we call targeted therapies. So rather than giving a generic drug that targets human cells in general, we now have drugs that target very specific molecular abnormalities. And so the goal is to try and find, is there a molecular abnormality that's specific to that patient or the cancer? And thereby giving them a drug that blocks that molecular abnormality, we improve the balance of effectiveness versus side effects. But the key thing we're realizing to do this properly is that to use these targeted therapies, we need a biomarker to guide its appropriate use. And it's really this shift from kind of broader chemotherapy to more specific agents or targeted therapy, which is what we call precision oncology. And so the big shift that's happened, particularly in the last 10 years, is when that patient comes in with a suspicion of cancer, we no longer just say this is lung cancer, this is breast cancer, but we have to do a deep dive into the biomarkers of that cancer. So what are the molecular features of the cancer, and sometimes even the molecular features of the individual with that cancer. And based on those biomarkers or molecular features, we then select a treatment where the hope is now we've picked a treatment that we're no longer guessing whether it's going to work, but the odds of it actually benefiting that patient go up considerably. And so essentially, this is kind of our move from sort of personalized medicine based on what we call histology or the type of cancer to precision medicine based on the biology.
So first question, when you say molecular profiling, is that what's used to determine the biomarkers, or is biomarkers the same as molecular profiling? And there's also the term genomic or gene sequencing. How are these all? Could you explain the difference between these terms?
Sure. So you hadn't seen my slides, but I guess it's a good segue. So a biomarker is basically any laboratory test that guides treatment. So in the case of oncology, we use biomarkers in several different scenarios. We most commonly use it to see if a patient has that biomarker, does that biomarker predict, or will that biomarker predict that that patient is more likely to benefit from the therapy? We also use it in the situation to determine, does the presence of that biomarker predict whether someone will be harmed from that treatment? And then in some cases, particularly leukemias, and even those with colorectal cancer who are familiar with a CEA measurement, for example, biomarkers can also be used to measure whether someone is actually responding to treatment. These biomarkers can be measured lots of different ways. A biomarker could be a blood test, so the CEA is a perfect example of that. A biomarker could be a PET scan, so a PET scan done to assess whether someone's actually responding to treatment. But in many ways, the shift we're making right now is we're shifting towards biomarkers in the cancer cell. And biomarkers in the cancer cell typically represent three components of the cell. So, quick biology lesson. Most of our genetic material is coded in DNA. This is what we inherit from our parents, and ultimately what can mutate over time and can contribute to cancer. That DNA ultimately becomes mRNA, which is an intermediate element, to finally protein. And it's really that protein that has the effect on the what we call the phenotype, or what that cell is actually going to do. So in the laboratory, the biomarkers we can test can either be the DNA, so we can perform something called sequencing. So we call it next generation sequencing, DNA sequencing, gene sequencing. They're all essentially the same thing. We're essentially trying to decode what that individual patient or tumor DNA is, and based on that code, determine, is there an abnormality of a particular protein? And if that protein is abnormal, perhaps we can give a drug against that protein and use a more precise therapy. For other situations, we might do it in RNA, and others for protein. Bottom line is, all of these approaches help us identify a biomarker, which will ultimately inform the treatment decision.
Can I jump in with another question?
Please.
So you, just to clarify, so biomarkers can also be discovered through PET scans and blood tests.
That's correct. So again, the generic term for biomarker is anything that informs a treatment decision.
Okay. And then when this type of profiling is done, this genetic or genomic sequencing or molecular profiling, same thing?
Correct. Yes.
Okay.
So when we talk about genomic profiling, we're usually focusing on the DNA or the RNA. So what that means is that we're taking a piece of the tumor. From that piece of the tumor, we're typically extracting the DNA and RNA, running it through a specialized sequencing instrument, taking that information, running it through a decoding software, and then using that decoding software to essentially develop a genomic blueprint for that patient's cancer. And then we use that blueprint to ultimately inform the treatment decision that we will make.
So this type of testing and analysis will show if there's changes in the DNA or abnormalities that have happened?
That's correct. And keep in mind that there's a couple of different types of changes that we're trying to look at in the DNA when making decisions about a patient. So most frequently, what we do is we look for changes in DNA of the tumor itself. So we call these mutations. So what has mutated in the tumor that is different from, let's say, a normal cell? And does that mutation ultimately allow us to direct therapy? Sometimes we also look at mutations not in the tumor, but in the patient themselves. And the purpose of looking for those mutations is to understand, is this patient at a particularly higher risk of developing that cancer or potentially other cancers? So we call those risk mutations. And so particularly for patients who might be familiar with things like BRCA1 or BRCA2 testing or Lynch testing, in those situations, we're not necessarily testing the tumor, but we're actually testing the patient's normal tissue. Usually it's just some normal blood that's circulating, to try and find mutations in genes that might make them more susceptible to getting cancer than the average individual.
So this type of testing now, this is more advanced looking at in the cellular level. Does every patient that's diagnosed with cancer have a patient profile created about their, have this molecular kind of profiling done? Is it every patient or is it only certain patients that get this done?
So unfortunately, at this point in time, this type of testing is limited to certain diagnoses. And the reason it's limited to certain diagnoses is that we're still learning a lot about cancers. While we've learned a lot about the biology of cancer, we don't know everything yet. And there are still many cancers where we're not quite sure what to necessarily do with the genomic information. By that, I mean, when we see a mutation or when we see an abnormality, it doesn't automatically lead us to access an approved drug. And when we can't access an approved drug, then it leaves us with the situation of, well, we may not have a test funded in that particular situation. Thankfully now, as we do more and more clinical trials, many clinical trials are being based on these types of mutations and biomarkers. So we're seeing more and more situations where through the clinical trial, patients are getting access to testing, and that will ultimately give them opportunities to potentially receive treatment. From my perspective, I hope within the next 5 years that this type of testing is standard of care for every patient that comes through the door. But unfortunately, at this particular point in time, broader genomic testing is really limited to very select cancers. The most common ones where we do routine testing tends to be lung cancer, colorectal cancer, melanoma, skin cancer, and leukemias. It's coming to other cancers. One where I see changes happening in the near future would be pancreatic cancer, potentially breast cancer as well. So this is an area that is rapidly evolving.
Mhm. Can you tell us a little bit about the role of immunotherapy as a precision therapy?
Sure. So right now, as an oncologist, when I see a patient, I essentially have access to three types of therapy. The first is what we call cytotoxic therapy. So cytotoxic therapy essentially consists of two broad approaches. One is chemotherapy. So I talked earlier about chemotherapy, how it's essentially an antibiotic against human cells. So we use it to kill cancer, but we know it has side effects. Radiation is another form of cytotoxic therapy. It's given in a different way. It's not necessarily injected into patients, although that's changing. There are some prostate cancer patients might be familiar with radioisotope treatment. And so the idea is injecting a precision molecule that is directed towards prostate cancers that has radiation particles on it to essentially try and treat those cancers from the inside. So those are what we call cytotoxic. They try and essentially kill that cancer cell by blowing it up, essentially, trying to blow up the DNA through either the chemotherapy aspect or the radiation aspect. I mentioned targeted therapies. So targeted therapies typically target a specific protein. So for example, in lung cancer, about 15% of patients have an EGFR mutation. If we then give them a drug that blocks EGFR, it works really great at treating their cancer. So these targeted therapies can either be pills that patients take on a daily basis, or they can be antibody drugs that we infuse in the treatment rooms. So it may look like they're getting chemotherapy because it's an infusion, but they're actually getting very specialized antibodies against a target. Immunotherapy is sort of our newest wave of treatment. There's basically three classes, and they're listed in order of kind of what we're using more and more commonly. So the most common treatment that we use are what are called checkpoint inhibitors. And there's lots of patients out there who might be familiar with PD-1 inhibitors or PD-L1 inhibitors or CTLA-4 inhibitors. These go by more common names like pembrolizumab and nivolumab and ipilimumab, etc. The bottom line is the way all those drugs work is that they help our body's own immune system recognize the cancer and try and essentially control the cancer. They have their own side effects, but they have been quite effective in changing the outcomes of many cancers. Melanoma, skin cancer, bladder cancers, and lung cancers come to mind. We know that these checkpoint inhibitors essentially try and allow the immune system that's already there to work better, but sometimes we need to give the immune system a helping hand. And so that's where this new class of T-cell engagers come on. The difference in the T-cell engagers compared to the checkpoint inhibitors is checkpoint inhibitors basically sort of set the immune system free. T-cell engagers basically say it grabs a hold of the immune system and basically brings it right to the cancer and says, look, cancer's here, come get it. So it, in some ways, can be a more effective treatment, but it also has more side effects. So these are elements that we have to balance. And then the third class is cell therapies. This is where a patient's immune system is actually taken out. We look for cells within the immune system that might work better against the cancer cells. Those cells are re-engineered and then basically given back to the patient. So now we've essentially put the immune cells that are really effective against the cancer in hyperdrive to see if they are more effective at controlling the cancer. So again, these are different approaches that can be used. As we go down in this list, they get more complex. And keep in mind that we can't just design a treatment and throw it into a patient. We have to be very careful about, has it been designed properly? Has it been tested appropriately in pre-human models? And then is it finally safe and is actually doing what we want it to do in humans?
Do we know of any risks of using this types of therapy? I mean, a lot of people understand the side effects of the cytotoxic therapies, but what are some of the side effects or risks of immunotherapies?
It's a great question. So for the checkpoint inhibitors, the most common risks are basically what we call autoimmune side effects. So people might be familiar with autoimmune diseases like arthritis and skin disorders like psoriasis, colitis, etc. So these checkpoint inhibitors, thankfully it's rare, but they can cause serious, essentially drug-related autoimmune side effects. So patients can get inflammation in their lungs, their liver, their skin, the bowel, joints, list goes on and on. So again, they're rare, but they can be quite serious. So we have to watch carefully for that. T-cell engagers can essentially do the same thing, but they can also cause some more serious side effects. There's something called cytokine release syndrome. This is where the immune response actually goes a little too far. And we essentially have artificially created what to the body appears like an overwhelming infection. And so we have to sort of respond to that and keep it under control. In some patients, it might actually cause inflammation in the brain and concerns from that. So there are safety concerns that we have to be very cognizant about. And the same thing with the cell therapies as well. So these T-cell engagers and cell therapies, they're much newer therapies on the block. They have shown to be effective in some rare cancers, and we're slowly expanding it out to other indications, but we're doing it very cautiously because we want to absolutely ensure that when we try to find better therapies, that we're not accidentally making things worse for our patients.
So when we look at the use of immunotherapy, how extensive is that at Cancer Care Manitoba right now, using this new type of treatment?
So it depends on the type of cancer you have. For lung cancer, colorectal cancer, skin cancer, even things like esophageal cancers and gastric cancers, bladder cancers, kidney cancers. Pretty much every patient who qualifies for treatment will potentially get immunotherapy at some point in their cancer journey. For breast cancer, for example, it's emerging as a treatment for triple negative breast cancer. It's not yet indicated for, let's say, some of the hormone sensitive breast cancers where we already have very effective hormonal treatments. I'm not aware of its use in things like brain cancers, and I'm not aware of checkpoint inhibitor use in leukemias, although I think there is some use in Hodgkin's disease, if I recall correctly. So, 10 years ago, we may have used checkpoint inhibitors only in skin cancer. Now, I would say we use them in probably well over 70% of cancers, and that number keeps increasing on a daily basis. In terms of the cell therapies and T-cell engagers, I think we're still looking at its use in probably less than 1% of cancers. It's still pretty early and things are developing. The other challenge with these therapies is that many of them are inpatient therapies and they require a whole sort of rejigging of the health system to be able to give the treatments efficiently and safely.
I did have a question from one of our attendees is asking, what is the recovery like from the side effects of people that have had immunotherapy? And once the immunotherapy stops, once the treatment is stopped, do the side effects continue? I know it is more recent, so we don't have the long studies, I guess, of how long these side effects go on, but what's your experience been?
Yeah, so first of all, it's a great question. So the in most patients, discontinuing treatment and putting them on a course of steroids, whether it's a short course or a medium course, usually is sufficient to sort of deal with the side effects associated with that treatment. There is the rare case where it may go on for longer, but I would say the most patients with stopping the drug and sort of just quietening down the immune system can be quite effective. What's interesting about those side effects is that getting those side effects and stopping the drug is actually not necessarily a bad thing in that situation. So a lot of the checkpoint inhibitors, what they're doing is they're kind of waking up the immune system to basically say, hey, look, there's cancer here. You might want to do something about it. When we stop the drug and give some steroids for a short time, we're just quietening the immune system down. We're not taking it away. So the immune system is still there. It's already been kind of primed by the drug. So the immune system is still there to keep the cancer under control. And at least in lung cancer, I can say I've got many patients where I've stopped the immunotherapy due to side effect. The side effects have settled down, but their cancers remain controlled for months or years after that decision to stop treatment has taken place.
A couple other questions from our attendees. One was, what type of treatment is alectinib for ALK? I'm not sure what ALK stands for.
Yeah, so alectinib falls under the category of what we call targeted therapy. So ALK stands for anaplastic lymphoma kinase, or ALK. ALK is mutated in 2% of lung cancers and rarely in some other cancers like inflammatory myofibroblastic tumors and I think some rare brain tumors as well. And so when we find that mutation, and we can find that mutation either through sequencing the DNA, sequencing the RNA, or looking for expression of that ALK protein, once we've confirmed that that mutation exists, we can give those patients alectinib, which is a targeted drug for the ALK protein. And patients typically take that a couple of times a day, and it is over 80% effective in shrinking cancer in those patients. And typically, on average, most patients with ALK mutated lung cancers, alectinib is able to keep that cancer under control on average for at least 3 years.
Oh, wow, that's great. Another question about some medication. What group does Zoladex and enzalutamide, I hope I said that right, and enzalutamide come from under?
Yeah, so Zoladex and enzalutamide also fall under the category of targeted therapies. So they typically are working on um, hormonal pathways associated with prostate cancer. So we know one of the main driving factors of prostate cancer is testosterone. So prostate cancers have what's called the androgen receptor. The androgen receptor binds testosterone. So any testosterone that's floating around in that individual is ultimately stimulating that receptor and causing those prostate cancer cells to grow. So Zoladex and enzalutamide are essentially blocking or causing the body to reduce its production of testosterone. By reducing production of testosterone, we're no longer stimulating those prostate cancer cells through the androgen receptor. So again, the targeted therapy.
Yeah. So, in terms of the access to these types of treatments, and you mentioned about clinical trials and randomized trial data, could you tell us a little bit more about how that all happens in terms of how a drug goes through this process and then becomes available?
Yeah, so to 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 develop drugs is a complex process. Um, on average, it can take, up to 20 years for a drug to go from a concept to actually widely used in patients. The fastest drug I've ever seen go from concept to approval was 6 years, and it was a drug called crizotinib, and it was just because a lot of things fell into place at the right time. But the process essentially of drug development is first we have to have patients. We have to have patients with a diagnosis. We then need to perform discovery research, and Dr. Katyal will speak to that later today. But it's essentially the idea of in the lab asking scientific questions about that cancer, diving down deep into the biology of that cancer, and trying to understand what makes that cancer or that individual's cancer different from everything else we see. Once we have a better understanding of the biology, hoping that either a drug exists or if a drug doesn't exist, essentially starting from scratch to make that drug. Then taking that idea of a drug against a target, confirming that it's safe in preclinical models, so in animals like mice, and to make sure that it works the way we want. And then finally do clinical trials in humans to see, okay, is this treatment, first of all, is it safe? So that whenever we introduce a new drug to a patient, the very first question we ask before we even try to figure out how well it works is it safe? Does it cause side effects that we need to worry about? Does it make the patient sicker than they are before they started the drug? Once we've confirmed it's safe, then we do the next layer of clinical trials, which is to determine how effective it is. How effective is it by itself? How effective is it compared to the standard of care? And once we've done that, then we can sort of introduce it to the larger population as a whole. And I put this as a circle because um, research around cancer and drug development can jump in at any of these points. It's not that it always starts with the patient and ends with the patient. Sometimes the discovery research can be on samples that have been donated decades ago. And Dr. Katyal might talk about the Manitoba Tumor Bank, where we've got samples from the 1980s. And so, patients may have donated samples back in the 80s and may never have benefited themselves from that research. But that discovery science that's continuing in the lab might lead to an initial discovery that might inform the future treatment of patients based on the information that we acquire. So it's a complex process. It happens sort of at different rates at different times. But the important thing about the drug development process is this is a global effort. So we work hand in hand with teams all over the world, both in terms of sharing the science at the bench side, but also working to bring in clinical trials, either through academic organizations like the Canadian Clinical Trials Group or through partnerships with pharma to bring effective drugs to our patients at Cancer Care.
Randomized trial data could you explain a little bit what that refers to?
Sure. So again, randomized clinical trials are to determine both whether a drug is safe and whether it's effective in patients. So most randomized control trials, we categorize them as 4 types of trials: phase 1, phase 2, phase 3, phase 4. Phase 1 trials are really that first time that drug is being used in a human. And the entire purpose of a phase 1 trial is to sort of say, is this drug safe to use in a human being? And often by the time we've got to that point, we know the answer, but we're doing the proper science to confirm that. Once that's been confirmed, then we move on to a phase 2 trial. The purpose of the phase 2 trial is to, again, continue to assess the safety of the drug, but now also try and determine, is it effective for the reason we're trying to use it? If we see a signal in a phase 2 trial, then we move on to a phase 3 trial. So a phase 3 trial is usually what we call a randomized trial. So you're taking the new drug or the new therapeutic approach, and you're comparing it head to head with the standard of care. That standard of care might be an existing treatment. That standard of care might be what we call best supportive care, which is just placebo or doing nothing. And at the end of that phase 3 trial, we can conclude, yes, this drug works better than the alternative, or you know what, it's not any better, so we've got to go back to the drawing board and figure out what is better. And then finally, we get to phase 4, which is even after we've done the phase 3, we've proven it's better, we don't stop there. Phase 4 is when the drug is actually in use, regularly prescribed to patients. We continue to monitor, does it continue to show the effectiveness that it showed in the previous trials? Does it continue to show the safety that it shows in the previous trials? So the scientific community as a whole is really trying to be rigorous to ensure that when we bring drugs forward, that these drugs are truly doing what we want them to do without causing undue harm to our patients.
So just to clarify, so the standard of care, is that based on what drug, the drug kind of hitting the most common features of a certain cancer, like being able to most broadly be effective? Is that how the standard of care is determined?
So it could be different things for different situations. So for example, we know for breast cancer that the number one treatment for hormone sensitive breast cancer is an anti-estrogen therapy of some sort. And the anti-estrogen therapy works very well. So adding in another drug with the anti-estrogen therapy may not be a great trial to do. However, when that anti-estrogen therapy stops working, perhaps the trial worth doing is comparing chemotherapy, which is often considered as the next line of treatment in that patient, with a new targeted drug concept. So that's one example. I'll go back to the crizotinib story. So crizotinib was first developed as a drug that targets ALK, as in that earlier question. So when crizotinib was first tested in a clinical trial, it was compared to chemotherapy because chemotherapy is what was our standard of care to treat those patients at that time about 10 plus years ago. And so crizotinib showed that it was way better than chemotherapy for those patients with the ALK mutation. When alectinib came along, well, it didn't make sense to compare it to chemotherapy because we'd already proved that crizotinib was better than chemotherapy. So when alectinib did its clinical trials, it compared it to crizotinib, and it showed in clinical trial that it was better than crizotinib. And so it essentially supplanted crizotinib as the new standard of care.
Couple more questions for you about one was just more generally, does targeted therapy work at any stage of the cancer?
In general, yes, targeted therapy can work at any stage of cancer. We know in metastatic cancer, which is where most targeted therapies are approved, it works best when it's given as the first line of therapy. It can still be effective when given as a later line, but in general, from a lot of our studies, it tends to work when it's given as that first line of therapy. Um, Targeted therapies can also work for earlier stage cancers as what we call adjuvant therapy. So most early stage cancers are typically treated either with surgical removal or surgery and or radiation. We can then sort of give a targeted therapy to help prevent that cancer's recurrence. That being said, to prove that, we do need to do trials, and in every case, we do trials, but many of those trials can sometimes take years to get a result back because, particularly when you've given a curative treatment like surgery or radiation, it might be many years before that cancer is at risk of coming back. So, yes, we can use it at all stages. We most commonly use it for advanced stages, but it's definitely coming more and more to earlier stages. Herceptin for breast cancer is the perfect example. When it was first approved, it was only approved for metastatic breast cancer, and now it's used to treat all stages of breast cancer.
So I guess one of the next question would be realistically, like what's financially what has to happen before more drugs are available, more of these advanced precision therapies are available? Is it a long process to have these new drugs reimbursed by the, I guess could you explain a little bit of that? Is that through the government has to approve it for funding?
Sure. So I promise this is my last slide, but in Canada we have a similar process to Europe. It's very different from the process in the US, although I'm not sure as of next week what the process in the US is anymore. But whenever a new drug is brought forward in Canada, first of all, a drug is typically brought forward after it has gone through a clinical trial. So a clinical trial has been done, whether it's been done in one country or several countries. The company that makes that drug typically applies to Health Canada. What Health Canada does is it reviews, is that drug safe to give? And that's the main question it's asking. And secondly, does that drug work for what its intended prescription is? Once Health Canada has approved that drug, that medication can be prescribed in Canada. But being able to prescribe the medication doesn't mean it is funded. So at this point in time, yes, a physician can prescribe it, but it doesn't mean that the provincial healthcare system will reimburse the drug. And so often what happens at this point in time for cancer drugs is a lot of companies develop what are called compassionate access programs. So the companies make the drug available for free while the rest of the process is happening. So the second step is what's called the health technology assessment. And so this is done now by Canada, the CDA, the Canadian Drug Agency, and Quebec has its own organization. And the purpose of the CDA and NS is to look at the safety, look at the efficacy of a drug, but also to look at the economics of the drug. How much better is it compared to the alternatives? How much is it going to cost? How is that ultimately going to impact the healthcare system? So they do sort of this comprehensive evaluation, and then they'll make a recommendation as to they agree that the drug should be funded versus no, they don't think this is appropriate for a Canadian population. So that's step two. The reality is that these all take time, and I won't get into the time right now, but the bottom line is that it could take up to 3 years to go through step one to step four. The next step is a price negotiation. So this is where the provincial health agencies form an alliance and essentially negotiate with the company what they're willing to pay for the drug. If a agreement is in place, then now the provinces can finally make a decision to reimburse the drug, and Manitoba Health through Cancer Care Manitoba will ultimately reimburse the drug. So this going through all four steps successfully is what it takes to get a drug reimbursed. As I mentioned, as soon as we have Health Canada approval, there may be compassionate access, but that is often at the mercy is not the right word, but I can't think of a better one, but it's often at the discretion, I guess, of the company that makes the drug. And so some companies might be very liberal and give access, and others may not. So this is essentially the process that happens here in Canada. On average, it takes about um, I think they say 18 months to go through this process. Some files can be longer, some files can be short.
Thank you so much, Dr. Banerji. This has been, obviously it's leading to some more questions. I do have some more questions here for you, but I'm going to leave them to the end of our session. And then I'll have all the presenters come back on so I can share some more questions with you at that point. Thank you so much. So we're going to bring back to the screen Dr. Katyal. And it's my pleasure to introduce you now. Dr. Katyal did his postdoctoral training at St. Jude Children's Research Hospital in the area of DNA damage and repair in neurodevelopment and neuro-oncology. In 2013, he began his independent academic research position at the U of M and Cancer Care Manitoba with the Department of Pharmacology and Therapeutics and the Paul Albrechtsen Research Institute. In 2022, Dr. Katyal took on the role of director of the Manitoba Tumor Bank. And in April 2023, he became the Manitoba institutional lead of the Terry Fox Marathon of Hope Cancer Centers Network and the Precision Oncology Initiative. That's a lot of words. And I'm sure that's probably just a glimpse of the work that you've been doing, Dr. Katyal. Thank you very much for being here.
Well, thanks for having me today.
So Dr. Banerji has spoken to the clinical trials and research, and one of the questions I think comes to mind is that this tricky thing, everybody always says, cancer is so tricky, it's so complicated. It's this ability for them to be mutating and evading treatments, becoming more resistant. How does that work if we're trying to be very specific about targeting something? Can we do that? And how long does that last for before then we have to come up with another drug because the cells are mutating and changing?
Right. Well, so first of all, Dr. Banerji gave a wonderful overview and made my job a lot easier with my part here. So some of what I may say may repeat or come at it from a different point of view, but there'll be some redundancy. So yeah, you're right. Cancer cells are known for accumulating mutations. But there's an inherent feature of cancer cells called genomic instability. So as Dr. Banerji talked about, we have DNA. DNA encodes RNA, RNA encodes protein. So that DNA, that genomic DNA, as the cancer cell is replicating, will incur a number of mutations due to DNA damage and breaks that occur, and cells will repair those, but that repair can be very imperfect. And that imperfect repair leads to changes in the genome, which causes mutations. So remember, one thing is cancer cells come from ourselves, right? So we start with our own genomic signature, our own genes. We have minor differences. We call them polymorphisms. And that's what makes us all look different, right? We are all human. So we have an overall 99.99% very similar function and how our DNA looks. But those subtle changes are what makes us different. And so when a cancer cell arises, it arises from one of our normal cells that goes bad. And so it has that initial same genetic signature that comes from a normal cell. But as it starts incurring mutations, it's not as if the genomic, the gene that is originally mutated now has changed and that mutation isn't there. It's a successive accumulation of mutations. So as each cancer cell divides, it may accumulate additional mutations, but the original founding mutations are there. And so a treatment that has been developed against a specific change or mutation can still be very effective, even if the cells are still mutating as a cancer cell grows. At some point, though, especially in the treatment progression, when drugs stop working as well, those mutations accumulate to supersede the efficacy of the drug. Okay, and so the cell takes on a different biology. And so we have to then identify how these new mutations has changed the biology of the cell. And so these drugs can remain very, very effective for a very long period of time until they don't. And then that's when you start getting secondary treatments and therapies, which is why Dr. Banerji was talking about some of the targeted treatments being very effective and used at the later stages, but now coming in fashion at the earlier stage. Now, keep in mind, things are not static. Dr. Banerji talked about the drug development process. It's not as if there's just one lab that's looking at one drug and it takes 20 years. There's thousands and thousands of labs, thousands of companies who are approving drugs constantly. So although it seems like a 6 to 20 year process is a very long time, it is. It's staggered. There's so many drugs coming along. And so what may work today and eventually stops working tomorrow, a new drug may arise over the next couple of years that you can switch on to a secondary, tertiary, quaternary type of treatment.
That's very hopeful to hear that. To hear you say that, it just, yeah, kind of reinforces the idea that there's hope from, all these drugs that are being developed. If we look only at DNA, is that restricted in some way in terms of treating cancer? If we were just now to focus only on DNA, would that be restrictive in some way?
So I want to put up a slide just as a reference here to answer that question. Let's see if we can share screen. It's going to be similar to what Dr. Banerji showed, but a different take on it. All right. So can you all see that?
Mm-hmm.
All right. So let's think of the cell as building a house. All right. And so we start with a blueprint in building that house. And that blueprint is read, and you make a frame. And you build that frame, and then you fill the frame. You put your windows, your siding, your sink, your carpet, your tile. And then at the final stage, you're putting in your electrical, your gas, your appliances, your switches, things like that, to turn these things on, turn these things off, open doors, close doors, things like that. And so very much in building a house, when you look at a cell, the DNA is that blueprint. And that DNA encodes letters, or is a bit of an alphabet to make a dictionary of words, to make your final dictionary, right? And so that DNA will specify the RNA. So the RNA is the frame of your house, and then the protein is the house. And then we have subtle changes. We call them post-translational modifications, PTMs. That's what turns on and off proteins and makes proteins work together. So on your question of whether looking at DNA is being very restrictive, yes, we're only looking at one aspect, but the DNA is the founder of the house. And so if you make a change in the house, let's say you don't include a beam, that house will fall, right? You don't reinforce a floor, you may be able to not go up to the second floor, right? You don't put in a sink in a bathroom, that bathroom's not useful, right? And so when you have a change of the DNA, it resonates throughout the entire house building process and makes it not less functional, less efficient. So starting a DNA is a very good point because it tells us what mutations may have been incurred. Again, we're comparing it to your normal cells. So we're comparing normal cells, the DNA structure, and what changes have been made in the cancer. And then that allows us then to look at targets, because we can assume that if there's a change in the DNA, therefore there's a change in the RNA and the protein, and it changes the function of the cell. So I'm a fundamental scientist who works on the bench. Part of my job is to look at, well, we know that there's a change in the DNA. It resonates through a protein. What does that protein do? And how does that change influence the protein? Sometimes the protein doesn't work. Sometimes it works too much. We also look at the switches. What switches it on? What switches it off? Sometimes a mutation changes the switch, right? And so it's the combination of all those things. Now keep in mind, DNA, when we're talking about DNA, we're talking about genes. There's about 22,000 genes. Those genes, they make RNA. You get lots of variations. And so you can make hundreds of thousands of RNAs and millions of proteins. So it's far easier to restrict your analysis to DNA at those 22,000 than to look at the millions and millions of proteins. That's not to say we're not doing it, because we have these new developments in computational biology and AI that allow, the computers are able to do it for us, right? So we're improving resolution and experiments and ways to analyze the cell so that we can start looking at RNA and proteins and the switches to make a more fine-tuned approach. But again, that's all a lot in the research stage. And hopefully we're going to get clinical trials that come out of that. But our best information comes by looking at the DNA and some of the RNA.
So are there other factors that we should consider, though, when we're talking about how unique each individual person is and their response to treatment? Are there other factors, though, to consider besides just their DNA and the genetic changes that are occurring there?
So there's a variety of ways to look at it. It's one factor is age. Did you catch your cancer fast enough? Were you monitoring ahead of time? Were you at risk? Did you catch your cancer much later on? Where is the cancer located? Has it spread? Age again tells you about fitness. You can certainly go in with surgery with a healthy 40, 50, 60-year-old, maybe some 70-year-olds. But as you're getting later in age, surgery may not be an option because that patient may not do so well with surgery. It's the same thing with certain treatments and drugs. In some individuals, the side effects that you may get with those drugs, you can withstand, and in others, it can be a very limiting factor. So we also look at, I was mentioning the subtle changes, and again, going back to DNA, but we have polymorphism. Some of the early analysis to see whether a drug works or not in certain individuals is to look at these subtle differences to see whether that drug will work. For instance, in the African Canadian population, there is a polymorphism that affects how well tamoxifen works. And so knowing whether you have that subtle change may influence whether you go on to tamoxifen for hormone-sensitive breast cancer or not. So it's a variety of factors put together.
Yeah. Can you explain or just clarify what a DNA repair pathway means? What does that mean when you refer to that?
Sure. So that's actually where my background training is in. We have in our cells these little machines, these proteins. Their sole function is to repair the DNA that gets damaged. We cannot prevent our DNA from getting damaged. Right now, I am incurring damage by breathing oxygen. And the light from the ceiling, the radiation from the ground, the air we breathe, we are incurring over 100,000 what we call DNA breaks in our cells per day in every single cell. So these little protein machines go in, find those breaks, and repair it, and repair it, and repair it. And they safeguard our genome and prevent mutations from occurring. Okay. Now, generally, that repair is pretty exact and specific, but sometimes we get too much damage. And if there's too much damage, the cell may not be able to keep up with that repair. And we have a normal process in our body called apoptosis, where the cell says, I can't keep up. If I can, I'm just going to kill myself and let another cell replace me that's healthier. Now, if the body loses the ability to regulate or kill itself and it stays, that's when you start getting mutations taking hold and the cell is operating less optimally, right? And you accumulate more mutations, more mutations, and it can lead to disease. And one of the diseases is cancer. Now, the same proteins that are safeguarding our DNA, their job is to repair DNA. And Dr. Banerji talked about chemotherapy and radiation therapy. The goal of chemotherapy and radiation therapy is, and 98% of the goal is to damage DNA so much to cause the tumor cell to say, I got to die because I just can't repair it. But the tumor cells, some of them become very tricky. And they say, well, we're going to really supercharge the repair pathways in the cell and keep up with that repair, right? And so your goal is to overwhelm the cell and kill off the tumor cell, but a small subset may adapt, repair too efficiently, and that's where you can get recurrence.
Interesting. A question you mentioned, one of the factors about other factors was also about how early you catch the disease. If somebody has a history of cancer in their family, should they do genetic testing? Is that something that people should consider doing to be able to know whether they have a predisposition to develop a certain type of cancer?
So it's a great question. And there's actually ethical considerations for that. So in terms of screening and general testing, do it, right? And there's many screening initiatives out put up by Cancer Care Manitoba. Take advantage of those. When it comes to genetic testing, it's a personal choice. And that genomic information, what you know ahead of time, has a domino effect. If you want to identify for yourself to know if you're at risk, and you feel that that's right for you, then go ahead and do it. But because of that family history, knowing that answer for yourself could impact a sister, a brother, your child. It could impact your risk for knowing your risk for developing a future disease. Insurance companies, right? Are you insurable? Knowing that for life insurance that you have a higher risk, and so there's a whole realm of ethics of genetic testing that's developing in terms of teasing through privacy legislation. If are you supposed to disclose? Who else has that data? So again, identifying your risk factor through genetic testing is very much a private choice that one needs to make in evaluating all the risks and benefits.
In terms of the research on new drugs and clinical trials that Dr. Banerji spoke about, is it possible to test drugs on tumor cells before they actually get given to patients in clinical trials? Is that a possibility? Does that work that way?
It would be lovely to be able to do that, but it's not part of clinical practice. It is definitely a research activity that we like to do in terms of making things better, right? And identifying how drugs may work in different disease models, different genetic models. You talked about the first mutation, and if you get subsequent mutations, we'd like to be able to test if a drug will still work. But in terms of applying it to a clinical setting, it is not part of the model. Now, there are developing trials and there are researchers that work with clinicians in which, for instance, I have a colleague of mine, she's a surgeon, in which she's a brain cancer surgeon. She takes out cells from that patient when they have the tumor removed. And so while they're in that phase where they're presumed tumor-free, still undergoing standard care treatment, they take those cells, inject them into a mouse, and they force those cells, they treat the cells in the mouse and force the tumor to recur. And the idea is that the recurrence is due to an accumulation of more mutations. And then they do genetic testing on those human cells that have grown out from the mouse to see what new mutations have developed and use it as a predictive model to see is it likely that the same genetic signature that has developed from that patient's tumor cells in the mouse is what may happen in 6 months or a year from now, and maybe predict a treatment regimen. Now, it's not part of clinical care. It is part of a research study that can inform a potential treatment down the road as part of a research trial.
What are your thoughts on in the developments in diagnostics and possibly the role of AI in all of this cancer research? Any thoughts on that?
Yeah, it's really revolutionized how we approach research, how even drugs have made it through. There's a whole field. I'll give you an example of what we call in silico drug discovery. So in silico means in the computer. So we have lots of information of how proteins are made, how they look, 3D modeling. We have what's called X-ray crystallography. So these are little renderings, kind of like taking Legos and putting them together. And you can use computers to predict what drugs may improve a protein, disrupt a protein, change how two proteins interact. And through this computer-based modeling, it'll say, ding, 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 this drug could work. And then you go into a chemical biology company, pull those drugs from a repertoire, from a library of drugs, and test them. And so it has sped up how we do research and discovery-based science in bringing new drug candidates into potential trials, so preclinical analysis and potential trials. But there have been advances in imaging, computer-aided imaging to pick up hard to detect cancers. We have new technology in how we treat cancers using image-guided treatments, PET-CT. AI and computer technology has revolutionized both the research and the clinical fields in terms of boosting capacity, resolution, and how targeted we can be with treatment.
A question from one of our attendees was asking about how does a patient get involved in research and studies and clinical trials, of course, but what can a patient do and how important is it that they participate in some of these aspects of research?
So Dr. Banerji mentioned the Manitoba Tumor Bank, and he's right. We have patient donated samples dating back to the 80s. And although some of those samples may no longer benefit the patient who donated, it's benefiting research. But now with the speed of research, we are now at a stage where the participation at donating their sample to research could come back and help them. There are certain clinics and certain biobanks, so that in the tumor bank, where we can collect samples during the patient's disease progression, during their journey, which may help possibly inform treatment down the road based on comparisons with earlier samples that are collected. So how a patient can participate, you talk to your clinician, talk to your doctor, get informed about trials out there, ask, do I qualify for a trial? How can I help with research? If there's a willingness, your clinician or somebody at Cancer Care can connect you. It's not to say that there's a trial for every single cancer type, or there's an ability to collect tissue from every single cancer, but ask. And if you're willing to participate, it really helps research culture, and I think patients really like to be part of that research question and contribute toward research of their own cancer and cancer research in general.
Thank you so much. We're going to have you come back on after Bev presents, and we'll have some more questions for you then. So thank you very much for this information. It's really helpful and promising, very hopeful. Thank you. So I'd like to invite our final presenter to the screen to share a patient's perspective. So Bev is a cancer survivor and a patient partner with Cancer Care Manitoba's Health Services Lab. And Bev, can you tell us a little bit about your role as a patient advisor at Cancer Care and the other things that you've been up to? It's quite a bit.
Well, fairly lengthy. But I'll keep it short. It varies. Like when I first became a patient advisor, I had also been a volunteer at Cancer Care Manitoba for 18 years at different levels and capacity. But the role of patient advisor really appealed to me because it was more academic in a lot of ways, and that's sort of my background. And at first, I helped with the patient bill of rights and responsibilities, and we edited it because they do it every 10 years. They review it, and they had us involved in that. And then I put together a video, and they put it on the website. I also was involved in reviewing the development of the Centers of Hope, and they're not in working order right now. They're just kind of in the development stage. And then I said, well, I like research. Research fascinates me, and to see the developments in cancer. And I was given the opportunity to join the Health Services Lab at Cancer Care Manitoba as a patient partner. And I volunteer with Dr. Delisle and her colleagues. And I reviewed some research proposals, and I've participated in a World Cafe.
Tell us about that a little bit, about the Labs World Cafe and what was involved with that.
Well, it was an all-day conference with patients, professionals, academics, volunteers, caregivers from all walks of life. And we met at the Forks, and I can't remember how many people. Dr. Dalal could probably tell you. And we discussed two main topics, and one was the nurse navigators and how and their role with I want to get this right. Their navigation to reduce inequalities in the healthcare system for individuals diagnosed with advanced and rare cancers in Manitoba. And the second topic was advancing precision oncology in the real world environment. And that was part that they received a grant for that part. I if Dr. Dalal can correct me, and funding to promote Aspire, which is what that is. Yeah. And they received a Preparing for Research by Engaging Public and Patient Partners Award for that research grant proposal, and that was part of the World Cafe.
Yeah.
And then, yeah.
So Bev, I just wanted to interrupt you for a second because I know you said about that you were a consultant in terms of asking for your input on the development of the Centers for Hope, and actually the Centers for Hope have, we're now operating out of it's called the Center for Hope here on McDermott, and there's one that's open at the Victoria General Hospital, one that's going to be opening soon in Brandon. So that contribution that Patient Advisors has made has really shaped what those Centers for Hope look like. So it's a really valuable work that you've done. And I know that you were also involved in the testing out of the Nuna app, which is a new app. And that's something you were diagnosed originally 20 years ago. Is that right? With
19.
19 years ago. Yeah.
So it'll be 20 now. It's 2025, isn't it?
So what is the changes that you've noticed in since that time in terms of more patient-centered care, more personalized medicine? What have you noticed in that time since that first diagnosis?
In 2025, it was very disjointed.
2020? In 2020?
No, 2005, sorry.
2005, okay.
Yeah, sorry. In 2005, it was very disjointed. Like you went through your family physician and you went through whatever surgeon he or she recommended, and you didn't really have much to do with the breast health center. Now it seems to be all concentrated. Like as soon as you have your mammogram and there's suspicion, you go straight to the breast health center and they sort of organize everything for you. Before it was very disjointed, you go back and forth to your GP, and and there was very little support, and I had very little support. Because I was at the Grace and at Assiniboine Clinic for most of my treatment, for my surgery and everything. They just sent me straight to a radiation oncologist. But I never got the support like you get now with the breast health center, where you go there and they give you all the information kits and follow up, and you just didn't get that in those days. We never had Nuna. Nuna is really good. In fact, I didn't have Nuna the second time around in 2021 because I was just pre-Nuna. But I would have loved to have been able to pick up an app and sort of contact somebody at different stages, but you just didn't have that.
So you've also, like Dr. Katyal, you're a member of the Marathon of Hope Cancer Centers Network, and it's a patient working group. Can you tell us a little bit about what your role has been with them?
Oh, with the patient working group, we meet monthly, and as a whole, and then we have branched off functions. And up until the first year, we were dealing with planning for a conference in Halifax, and so my function with my group was we planned the logistics, whereas other people planned the topics, et cetera. And the workshop that we planned was on precision oncology. And we had a researcher from Vancouver come in, video conference, and explain genome sequencing, which was just very difficult to understand. But yeah, and then this following year, in 2024, helped plan some of the logistics for the Terry Fox scientific meeting in Toronto, like our role, like how to implant patients within the conference. And now it's taken on another stage, and we reviewed 32 research grants that were submitted to us, and we gave out close to $2 million in research grants.
Wow. So what qualifications do you need to participate in these types of committees as a patient? Like,
you have to have cancer or be a caregiver. Yeah.
That's great.
You apply,
yeah.
know, and
from your perspective, why do you think it's important that patients are involved and have this role in research and in advising about cancer treatments and cancer patient care? Why do you think it's important for patients to be involved?
Well, you're the ultimate, you're the recipient of whatever they do. And they got to respect and reflect your needs and what your ultimate wishes are.
And that is being the patient-centered approach and the personalized care.
Yeah, and to have a say, you know, like just like with the research grants, we were able to say what we thought was important in terms of research.
Yeah, and also for the Centers for Hope as an advisor, you were also able to share what you thought would be important for those centers.
Yeah.
That's great. Well, thank you so much for your contribution and for being here today. I'd like to keep you on screen as well and invite Dr. Katyal and Dr. Banerji back to the screen because we have a few more questions and not that much time left, but there were some questions that I didn't get to. So I do have a comment from somebody I'd love to share because they said, immunotherapy saved my life. I received nivolumab for 2 years and also CBRT to treat my stage 4 sarcoma, and said, what a blessing. So just wanted to pass that good news on to you. One person has also asked, do people, or what would you say is the biggest barrier for someone to access precision oncology in Canada? I mean, we've talked about the process of clinical trials, but if you were to summarize what the biggest barrier could be, what would you say it is?
I guess I'll take this. There's probably a couple of barriers right now. The first really has to go with finite healthcare resources. We have to remember that that biomarkers, the use of biomarkers ultimately informs better care. And that's the reason we are really trying to develop that area. It also leads to better patient outcomes, but those outcomes are tied to greater use of effective treatments. And the reality right now is many of those effective treatments are also very expensive. There's a significant healthcare cost associated with this. There's the cost of the drugs, there's the cost of healthcare resource utilization, which is all fantastic because it's tied to improved outcomes of our patients. But as we're all aware, the healthcare system has lots of stress points, lots of areas of need, whether it be long-term care facility, emergencies, numbers of doctors, nurses, CT scanners, you can go on and on. So whenever we're making a decision about bringing in new technologies, new approaches, we have to make a case for what we need and what we're doing against everything else that's happening in the healthcare system. The other barrier I would say is just how, I guess, healthcare is governed a little bit. So part of that is in Canada, we have a federated system where, Health Canada can dictate this is how these are the general rules how healthcare should be practiced. But at the end of the day, the implementation is provincial, and there can be major sort of province to province variations. In many ways, I would argue that Manitoba, we're lucky. We sit at the better end of that spectrum. It may not seem that way all the time, but we have access to a lot of things from a cancer perspective that my colleagues in other provinces perhaps don't have access to. But even in our own provincial jurisdiction, one of the issues we run into is that healthcare budgets are siloed. So there's a cancer budget, there's an emergency budget, there's a diagnostic budget, there's a primary care budget, there's a drug budget. So often when you use personalized medicine properly, what you'll see is things like drug budgets go up, testing budgets go up, but then you should then see savings in other areas like fewer emergency visits or less need for hospitalizations and things like that. But because the budgets for all of those are separate, it's very hard to kind of move those pieces around to make the whole system work efficiently and the way it should. I know that's not the answer everyone wants to hear, but that's the reality. But there are efforts underway to kind of break down some of those barriers, and it's a multi-pronged effort. And I'm in a very privileged position to say that kind of in my, I guess now 13 years of practice here, there have been significant improvements.
Thank you. One of our attendees asked, is there a way to see if a patient that's undergoing chemotherapy or radiation to determine if their cancer at that time during treatment has spread, or if the patient has now cancer-free? Is that a routine test that's done during treatment?
It's not yet a routine. It's not yet a routine test that's done during treatment, partly because it's very difficult to interpret during treatment. So first of all, even before we start treatment, the entire healthcare team does a very extensive workup to try and determine the stage of the patient. And the reason we do that workup to determine the stage is we want to know, even before we start, has this cancer spread or not? Because the approach we might take to treating that patient will differ based on whether it's already spread or whether it looks like it hasn't. And so particularly when it hasn't, that's where the role of our surgeons and radiation doctors really plays an important role to try and intervene before it has a chance to spread. Doing these types of tests actively during treatment is that when you do things like CT scans or even blood tests, you may actually get a flare where the cancer looks worse before it looks better. And so if you make a decision to stop treatment based on kind of that temporary image, then you may actually be doing a disservice to a patient. There's other tools that are coming, such as circulating tumor DNA or cell-free DNA. The potential is quite neat. There's several issues with it. One is even in best case scenario, the test only works in about 70% of patients. So for the other 30%, what do we even do? And then for again, you can see sort of random changes in those cell-free DNA. So again, we don't yet know exactly how it should be deployed.
Do we know when screening for lung cancer is going to begin for smokers?
This is a bit of a loaded question. So, so for smokers, screening for lung cancer is starting to be rolled out. There are a few hiccups to widespread rollout. The screening for lung cancers right now is restricted mostly to patients with a smoking history or with the prior cancer history. It is, I saw in one of the questions, is it available for non-smokers? And the answer to that question is no. Screening is not yet available for non-smokers. And there's a variety of reasons for that. One, the studies to prove it's effective has not been done in non-smokers. And the second is whenever we do screening, we have to weigh sort of the cost versus the benefit. We have not yet determined that the cost benefit is there to do it in non-smokers. I apologize for the dogs in the back.
That's okay. We did talk a little bit about clinical trials. There's a question about accessing clinical trials. So Dr. Katyal had said, and I think Dr. Banerji talked to your physician, your oncologist to see what you might be eligible for, to see what's happening.
Yeah, so the clinical trial space is constantly changing. So as I mentioned earlier, clinical trials aren't just happening in Manitoba, they're happening all over the world. And in fact, when we open the majority of clinical trials here in Manitoba, there's probably at least several dozen sites around the world that have opened the same trial. And so two things come into play. One, it means patients from all over the world are being recruited to those trials. And often these trials have very specific numbers of patients they're trying to enroll on the trial. And once that number has been reached, the trial is closed so that the data can be analyzed. Especially in the current day of precision medicine and use of biomarkers, first of all, for patients to be eligible for the trial, they have to be biomarker positive. In many cases, that might represent 1% of the patients with a particular diagnosis. And so by the time the trials are open, by the time accrual happens across the globe, at any given center, you may only actually be able to enroll 3 or 4 patients. As Dr. Katyal mentioned, there may not be a trial for a specific patient's biomarker. And that's a combination of either we don't know the biology well enough to develop a drug, or for whatever reason, we can't get that trial open in Manitoba. He gave excellent advice, which is, as a patient or as a patient advocate, always ask the practitioner if there's a trial relevant to the situation. Ideally, there would be a trial locally, but even if there's no trial local, there may be one nationally or internationally. If there is, then some patients might be motivated to pursue trials at another center. There are barriers to that. A lot of it is financial for patients to go elsewhere. Going for a trial in another province is not something Manitoba Health pays for because that's research, it's not standard of care. But it's always good to ask about the availability of trials, as there's no harm in asking that question.
Thank you. We're running out of time, and so I have just one question, but I do want to mention that if I didn't get to your question, please send me an email. My email will show up in the Zoom email that you'll get that has a link to our survey that we invite you also to complete, because your feedback helps us plan future sessions. So my email will be there, and if I didn't get a chance to ask your question, please let me know, and I will forward the question to Dr. Banerji or Dr. Katyal or to Bev so that we can answer your question. One last thing that I would like to ask, though, is a question from one of our attendees that said, since when you began your career, are you noticing more new cancers, but also more suitable treatments for treating them readily? What are your thoughts on that?
So the answer to both those questions is yes. We're seeing more new cancers, not because cancer is more common. So if we look at the statistics around cancer, the absolute number of cancer cases in a year are going up, but they're mainly going up because the population is aging. And we know that one of the biggest risk factors for cancer is just living longer. And so if you actually correct the statistics or adjust the statistics for the age of the population, the actual rates of cancer are going down. And that's through efforts like prevention, lifestyle changes, etc. And more importantly, death related to cancer is going down, and that's through a combination of both prevention, but also much better treatments. I can speak to sort of the effectiveness of treatment in lung cancer. There was a time, or when I trained, 1% of stage 4 lung cancer patients survive 5 years, and probably that 1%, either the biology was very different or maybe we didn't diagnose it as properly as we should have. Now that number is approaching 20%. So 20% of stage 4 lung cancer patients are surviving 5 years. A sort of sobering thought on that, though, is that even today, only 20% of patients with stage 4 cancer are making it to Cancer Care Manitoba to start treatment. And that's the same number as it was 30 years ago, which means that in about 80% of patients, we're even missing the opportunity to start them on treatments. So our treatments are getting better. Our treatments are getting better every day. The outcomes of our patients are getting better. But we also need to get our system to work efficiently to get those patients through our doors so that we can offer the treatment.
Any thoughts
If
on
I could,
what? Yeah, go ahead, Dr. Katyal.
no, if I could add, and so we're also seeing, because patients are living longer, we're getting varied subtypes of cancer. We're getting more complexities to cancer, but also the technology that's been developed to detect the molecular subtypes of different genes and all that are composed of cancer are increasingly complex. So the research is getting more difficult. Even though we're learning more, it's getting more difficult, although that the rates are getting better.
Wow. Great discussion. So many more questions come to mind, and we could talk about this. But yes, I do invite our attendees, if I didn't get to your question, please just forward it to me and I'll make sure that we answer it. And I just want to say a thank you to all of our guests and to Dr. Delisle, who was instrumental in organizing this webinar. And I really appreciate all the good questions that we've had coming in. So thank you all for your participation, and take care for now.